Okay, this is a presentation on the grade 5 passive mobilization, also known as spinal manipulation, given by myself, Michael Jeanfavre, for the Stanford Healthcare Clinical Residency in July 2023. Okay, any conflicts of interest and/or financial disclosures? I have none, so there's no current or past relationships with commercial entities related to this topic, no commercial interests, and nor do I have any speaking fees for the current program. The overall objectives for the pre-lecture as well as the live lecture will be for the residents and the audience to be able to define a high-velocity low amplitude thrust, or HVLAT, explain the current theory of a cavitation, understand the refractory period following a cavitation, appraise and understand the contraindications of the HVLAT, evaluate the risks for and against a high velocity low amplitude thrust versus like a non-thrust, demonstrate safety and proficiency of the performance of the HVLAT manipulation for the upper cervical, cervical-thoracic, thoracolumbar regions of the spine, and include pre-thrust positioning and application. All right, and so we're going to start off the presentation with the introduction and definition of HVLAT, and that will be presented by Taylor.
So we're going to start off with our introduction and definition of what is an HVLAT. A high velocity low amplitude thrust is a therapeutic movement that's performed at a high speed within a relatively short distance within or at an in range of motion. And these techniques are designed to restore joint motion, particularly in joints that have a restricted range of motion. In 1998, the APTA Guide to Physical Therapist Practice commented saying that this is a skilled passive movement to joint and/or related soft tissues at varying speeds and amplitudes, including HVLATs. And then it was updated in 2014 saying that it was a skilled hands-on movement and skilled passive movements of joints and soft tissues intended to improve things like range of motion, joint relaxation, help modulate pain. And in those manual techniques included things such as traction, massage, and then mobilization and manipulation.
So there's much confusion around the terminology when it comes to spinal manipulation, high thrust manipulation, joint mobilization, grade 5s, chiropractic adjustment, and I want to take a moment and really define and delineate the difference between these terms. So chiropractic adjustment is defined as any force a chiropractor delivers to a patient's joints for therapeutic purposes. May be delivered manually or by use of adjustment instruments or by the use of specialized equipment such as padded wedges, mechanized drop tables or activators. An adjustment can only be used if the chiropractor has detected a subluxation and has the therapeutic intention of removing or correcting said subluxation, and that's dating back historically to the foundational roots of the chiropractic practice by the Palmer postulate. And the subluxation is defined as a complex of functional and/or structural and/or pathological articular changes that compromise the neural integrity of the system and may influence an organ system's function and general health. And thus, if we're utilizing the strict definition and the historic traditional definition when it comes to an adjustment, well, if an adjustment fixes a subluxation, then a subluxation has to otherwise be present. Presumably, traditionally, subluxations only occur in the spine, thus an adjustment is applied to the spine. However, there has been evolution of these definitions since, and different shall we say, camps or theories within the chiropractic profession. Some of the current providers hold steady to the standard definition that was formed off the Palmer postulate, and then others have since evolved it. But for all intents and purposes, a chiropractic adjustment requires a subluxation to be present, because an adjustment is intent is to remove and or correct it, and a subluxation is defined there. Now, this is different than a spinal manipulation, and though within the chiropractic profession there are manipulations versus adjustments, and the terminology that is often used by physical therapists and also used within the guide of physical therapy practice is defined in most states under this Practice Act and using similar terminology, but does not distinguish among the subtypes of the manipulations. This being said, oftentimes clinicians and often a lot of the research within physical therapy will differentiate between thrust and non-thrust manipulations, and they'll describe it as such. A thrust would be a high-velocity, low-amplitude therapeutic maneuver within or at end ranges of motion, whereas the non-thrust would be those manipulations that do not involve a thrust or high-velocity amplitude movement. Going a little bit further in there into that definition of spinal manipulation and pulling from several resources to develop this definition. So the most recent was Evans in 2023, Olson in 2021, and then pulling from Gibbons and Tehan in 2016 in their text. A spinal manipulation is defined as a manual therapy technique that involves a high velocity, low amplitude therapeutic maneuver within or at the end ranges of motion. And it is performed with the intent to create a separation or gapping of the opposing articular surface of a synovial joint caused by the force applied in parentheses, perpendicularly to, as defined by Evans, to those articular surfaces that result in a cavitation within the synovial fluid of the joint, which often leads to the audible sound, or one form of the audible sounds. As you will see, there are multiple frequency of sounds that can be heard with a spinal manipulation. The intended purpose of applying these techniques within the physical therapy profession is to restore mobility. This could be intra and or extra articular structures, removal, reduction in the synovial fluid viscosity, hence like popping the knuckle in the classic study that has shown that the formation of the gas bubble within the synovial fluid following the MRI, or within the MRI as the individual pops their knuckle. It is intended to provide an analgesic response, reduce reflexive efferent muscle tonicity, improve joint positional sense, improve volitional muscle function, or a combination of the above. And the mechanisms by which these changes or these physiological implications of providing the manipulation technique occur are through neurophysiological, endocrine, and or musculoskeletal mechanical mechanisms. And to further delineate the spinal manipulation from that of the chiropractic, again, a physical therapist may not claim that any manipulation services they provide is in any manner a chiropractic adjustment, at least within the state of Wisconsin, but often we will be cautious within our profession to differentiate our treatments from that of a chiropractic adjustment. As stated previously, according to the Palmer principle, an adjustment is only applied to in the presence of a subluxation. Since our profession doesn't necessarily acknowledge the terminology of a subluxation, then by definition we cannot otherwise provide an adjustment. The physical therapy profession does not utilize manipulation to manage or co-manage or even prevent diseases of conditions in other body systems. That means systems other than the neuromuscular system. Whereas if we look at the historic and the traditional schooling of chiropractic, and the philosophy is that these malalignments or these subluxations within the spine can influence energy and or nerve flows and causing entrapments that can lead to diseases in other non-neuromuscular body systems. But that is indeed not the case within our profession. We do not subscribe to that. And so for purposes of this presentation, these terms will be used interchangeably. The high velocity, low amplitude thrust, or HVLAT, grade 5 and or joint manipulation or spinal manipulation will be synonyms of one another. All right, and so we're going to start off the presentation with the introduction and definition of HVLAT, and that will be presented by Taylor.
So here's the clinical application, and here are the indications for why we might apply a high velocity, low amplitude thrust. Some of it can include joint restrictions, so hypomobilities, joint fixations, acute joint locking, adhesions. Might be looking to restore bony alignment, or if we have a meniscoid entrapment, or if there's a displaced disc fragment. We have motion loss with somatic dysfunction or just pure somatic dysfunction. Also looking to modulate pain, release endorphins, relax muscles, and even thinking about reprogramming the central nervous system. Again, we have our clinical prediction rules to help guide us as well. And so that takes us into the OCS testing, where we see that the clinical prediction rules pop up.
Okay, so though clinical prediction rules are used consistently with our clinical practice guidelines for physical therapy, and they are often spread throughout the standardized examination for the orthopedic clinical examination and clinical specialist exam. They have their limitations, and I feel the necessity to give this disclaimer, even though we will be responsible for presenting what is the OCS prep material that includes these clinical prediction rules. So what are clinical prediction rules? So they use baseline criteria, that is treatment effect modifiers, identified from a physical exam to inform the type of treatment that a patient should preferentially receive. So essentially based upon the physical examination that is performed on a patient, they will present with certain factors will be identified, predicting whether they will be a responder to a particular intervention, in this case the intervention being spinal manipulation. And why do they exist? Their purpose is really to better match patients to treatments based on their predictive responsiveness to the intervention, independent of a diagnosis. That being said, that sounds a little bit counterintuitive as far as the absence of a diagnosis or independent of a diagnosis. Really, it's like, okay, you're presenting with neck pain. We haven't really specifically diagnosed you with cervical radiculopathy or muscle strain or osteoarthritis of the cervical spine, etc. Rather, we're just looking at these predictive variables, and it doesn't matter, or independent of what your actual diagnosis is. If these modifiable factors are identified on your physical exam, then it can be rather predicted whether you're going to be a responder to this intervention or not. Okay, so then what are the limitations of the clinical prediction rules? So they're often based on derivation studies, at least some of them. And so this, we can't with confidence, and it's inappropriate to apply a clinical prediction rule simply based off a derivation study in clinical practice. It requires a follow-up validation study or studies using different populations, using different clinicians and different centers in order for that prediction rule to be substantiated and have good external validity beyond just the scope of practice and the specific unique patient population that it was derived from. The second, the CPR studies are often underpowered, meaning that there's too few subjects. It's often recommended that you need at least 10 to 15 subjects per predictive variable within the CPR. So again, if you have, for instance, if you have 5 predictive variables, you need anywhere between 50 and 75 patients. At times, it's even recommended that you have over 100 patients for these derivation or the CPR generation studies. And as a result, if it's underpowered, then it usually results in large confidence intervals. And at times, these studies, the CPR studies, don't actually report the confidence intervals. And so a large confidence interval demonstrates a lack of precision of the prediction that the individual would otherwise potentially respond. For instance, if you had a control group and you had the individuals that would otherwise respond and who met the criteria, though the mean of that cohort that met the criteria would be responding, you potentially would have some individuals that would respond really well and some that would respond very minimally. And so the confidence intervals actually matter, and thus they need to be reported, and oftentimes they're very wide based off the underpowered study. Oftentimes the factors or the variables that are used within the CPRs are prognostic factors rather than prescriptive factors. That means that the rules incorporate factors that are identifying people who will get better via the natural history progression, irrespective of the intervention that they otherwise are given. And so if we're looking at spinal manipulation, for instance, right, so someone comes in with acute neck pain, they have low fear avoidance, they have some asymmetry with their rotation, for instance, would be one of the clinical prediction rules. This individual, yeah, you can do the manipulation, and then if you track them over time, they would get better, but they may otherwise get better because of their variables that you've otherwise identified as being relatively acute. We know that 80% of neck pain or spinal-based pain can self-resolve within 6 weeks. We know that these individuals are young. If they don't have fear, then they're probably going to be doing more movement rather than lying in bed or feeling as though they're disabled, and so on. Fourth, use of non-mediating factors. So ideally, the variables in question of the prediction rule should have factors that can be mediated by the intervention themselves, suggesting that the intervention is actually making a change in this individual. Oftentimes, the age, gender, or duration of symptoms cannot be mediated by the respective intervention. And then fifth, the CPRs are prediction of success is specific to the outcome used. So, for instance, if you use the Oswestry Disability Index for the low back, which is a questionnaire for how functional or how disabled someone is based off their low back pain, if you use another outcome, then the variables may be completely different. So the clinical appropriate CPR should hold up and demonstrate improvement regardless of the outcome used. For instance, like if you use like a Roland Morris or a start back tool, if the CPR was actually robust and resilient, then regardless of the outcome measure that you provide to the patient after your manipulation, you would expect them to improve. But unfortunately, what has been shown is that in the same population, if you use either a different cut point on a given tool, such as the ODI, or if you use a completely separate outcome measure that still measures the same construct of low back disability, there are different variables that are identified, which again just speaks to some of the fragility of the CPRs.
And so for cervical manipulation for neck pain, we have Puentadora in 2012 looking at when is it appropriate to manipulate when we have neck pain. And they suggested that if you have symptoms less than 38 days, if you have a positive expectation that the manipulation will work, if there's a side-to-side difference in cervical rotation of 10 degrees or greater, If there's pain with PA spring testing of the middle cervical spine, then 3 out of the 4 variables presents with a 90% probability of success, and all 4 of the variables, if a patient has it, puts us at a 100% probability of success. We see that having 3 out of 6 variables put them at a 74% probability of success. If they had 4, it bumped them up to 89. If they had 5, put them all the way up to 100. 90 days, put them with 3 out of the 5 variables having an 89% chance of success, and if they had 4 out of the 5 variables, then they had 100% probability of success. Here's a big one for manipulation for low back pain, given by Flynn et al. In 2002, which you might remember from your treatment-based classification systems. Having duration of symptoms less than 16 days, having at least one hip with 35 degrees or more of internal rotation, if they had a hypomobile lumbar segment, no symptoms distal to the knee, and if they had a FABQ work score of less than 19, 4 out of the 5 variables put them at a 95% probability of success, and if they had all 5, it knocked them all the way up to 100. Here's Cleveland et al. Looking for thoracic manipulation for neck pain, and no symptoms less than 30 days, no symptoms distal to the shoulder. If looking up does not aggravate their symptoms, they have a FABQ-PA score less than 12, diminished upper thoracic spine kyphosis, and cervical extension range of motion less than 30 degrees. Having 4 out of the 6 put them at a 93% probability of success, and having 5 out of the 6 put them at 100.
Okay, and in the subsequent videos, we will go into the precautions, contraindications, the pre-manipulative assessment. That will be part 2 of 4 for this lecture series. Okay, thank you all so much for listening. Please feel free to leave your comments, questions, concerns, and feedback in the sections below, or contact one of us, that is to say myself, Taylor, or Lauren directly. We'd be happy to answer and provide further detail when and where appropriate.